Hello friends, in this session of Radio Shorts, we'll be talking about a case of a 81-year-old gentleman who came to us with bleeding per rectum and the biopsy revealed it to be adenocarcinoma of the rectum. So in this next 5-minute session, we'll be learning about almost every important thing that we need to remember from the radiological point of view in cases of carcinoma rectum, and we'll also understand the importance of a structured report that we should all follow in our institutes. To begin with, let's have a look at the videos that we've already looked at. This is an axial video, an axial section, and first thing that we need to look at is the sequence. So because we can see that the urine or the fluid in the urinary bladder is appearing hyperintense, this is a T2 weighted sequence. Then the next thing we have to look at is the rectum. So what do we see in the rectum? Can you see anything abnormal? Yes, I think everybody of you would be able to pick out that there is some abnormality, some intraluminal growth which is present in the rectum, and it is present along the right lateral wall of the rectum. There are so many other structures that we also need to look at. I just want you to have a quick look at this video because when we talk about the importance of adjoining structures, we'll be coming back to it. Now before we go ahead, I want you to have a look at the sagittal video as well. What do we see in the sagittal video? The same findings are pretty much seen in the sagittal video. Here we can see that there is a growth which is seen all along the rectum, and this growth is showing an altered signal. This is not showing the normal signal, it is appearing slightly hyperintense to the rectal wall. So what is this case? This is a classical case of adenocarcinoma of the rectum. Now we'll be talking about what are the important things that we need to mention in our structured report of CA Rectum. So these are the most important things that we need to mention in our reports whenever we're looking at a case of CA rectum. First is the location of the tumor. Second, the morphology of the tumor. Third, T-staging. Now you'll be surprised to know that on MRI, we can give T-staging of the tumor as well, and we don't really need histopathology to do our work. Then, whether there is involvement of internal or external sphincter. CRM, that is circumferential resection margin status of the tumor. Pelvic side wall involvement. Extramural vascular invasion, and end staging. So this is the basic things that is required of a radiologist to give in his or her report of a CA rectum. We'll be looking at these one by one. First of all, location, the most important thing. So how do we divide different parts of rectum? So we have to look at the anal verge. Anything which is located within 5 centimeters of distance of anal verge is lower rectum. Anything which is located between 5.1 to 10 is mid rectum. And anything which is located 10.1 to 15 centimeters is upper rectum, and anything which is located above 15 centimeter is a pure sigmoid colonic growth. Sigmoid colonic growth. Second thing, morphology. What do we mean by morphology? By morphology, we mean what is the shape of the tumor. So here we can clearly see it's a semicircular growth. Many a times you can have a concentric growth that is through and through the length of the rectum. The entire circumference of rectum may be involved, and sometimes you can only have a polypoidal growth. So this is a classical case of a semicircular growth, and whenever you see a semicircular growth, you also have to tell till which point to which point it is extending based on clock position. So here we can see it is extending from roughly 7 to 11 o'clock position. So what have we learned so far? It is a tumor which is involving the lower rectum. It is a semicircular growth in morphology which is involving 7 to 11 o'clock position. Next important thing is sphincter involvement, which we can see only on a coronal image. So in this coronal image, I hope everybody of you would be able to see that this is the external sphincter, which is nothing but basically the skeletal muscle, and this is the internal sphincter, which is the smooth muscle. And if you see carefully, there is a bit of soft tissue which is extending along the internal sphincter on right side. So in this case, we can safely say that there is involvement of the internal sphincter. So this is internal sphincter involvement predominantly on the right side. This is important because this has to be told to the surgeon. Once he knows whether there is sphincter involvement, this can have important repercussions based upon the type of surgery that he's going to perform and also whether there is a risk of incontinence or not. Next, MRF. What does MRF actually stand for? MRF stands for mesorectal fascia. To understand mesorectal fascia, first of all, we'll have to understand what is mesorectum. So this entire tissue is rectum, and everything which is present outside the rectum, this bright colored tissue, which is nothing but fat, is the mesorectum. And this mesorectum is actually ensheathed by a fascia which appears hypointense on all sides, and it is called by the name of mesorectal fascia. To understand it, I want you to have a look at a different case which has been taken from literature, an article from Radiographics. What do we see here? We can see that there is a faint hypointense rim present here, faint hypointense layer present here. This is mesorectal fascia. Here we see that this tumor is extending inside the mesorectum. It is predominantly an exophatic tumor which has gone on outside the rectal wall and inside the mesorectal tissue. So this is one of those cases where mesorectal fat is invaded. When we talk about the mesorectal fascia, the only important thing that we have to remember is if the distance of this tumor from the mesorectal fascia is less than 1 mm, then it means that mesorectal fascia is invaded, and this is something which we have to mention in our reports because this is not the patient which can be taken up for total mesorectal excision. If there is a tumor which is going on and involved the mesorectal fascia with a tumor contact, then there is no doubt about it. It is definitely involving mesorectal fascia. But if the tumor is extended up to a distance of 1 mm from the mesorectal fascia, then also it means that the tumor has invaded the mesorectal fascia. Now let's have a look at our case. Do you think mesorectal fascia is invaded? Not at all. We can see that the mesorectum is all clean, and this is the tumor which is well confined by this hypointense muscular layer of the rectum. It is not going outside the rectal wall, and so there is no chance of involvement of the mesorectal fascia or the mesorectal fat. Next important thing is staging, something that I was talking about from the beginning. We can actually give the T-staging of the tumor based on MRI as well. So this is the rough diagrammatic representation of the various stages of CA rectum. T1 stage is the tumor which is present or confined within the submucosa. When a tumor goes on and extends up to the muscularis propria, it is T2 stage tumor. If it goes outside the rectal wall inside the mesorectum, it's T3. And based upon the depth of involvement, T3 has been further divided into T3A, T3B and T3C. Then if it involves the anterior peritoneum, it is T4A, and if it goes on and invades the adjoining organs, it is called as T4B. So let's have a look at our tumor. Now looking at this tumor, I want you to tell me what is the staging of the tumor. So when we look at the rectal wall, the outermost layer is hypointense. Why is it hypointense? It is hypointense because it is composed of muscle layer. And if you see carefully, we can see that the tumor is very well confined within the rectum, within the submucosal fat, and this black layer is not breached anywhere. It means it is a tumor which is a T1 tumor, a tumor which has been detected very early, which is predominantly involving the submucosa. It has not extended into the rectal wall, in the muscular layer, or in the mesorectum. Now let's talk about another very important feature, that is extramural vascular invasion. So anytime if you see that there is a prominent vessel that you can see here or you can see here which is seen extending from the level of tumor into the mesorectum. So this is the tumor, and through the tumor we can see that there is a vessel extending into the mesorectum, and it means that there is involvement of the extramural vascular status. So this is again a case which is taken from literature. You can go through and read about it, but in our case we didn't find this extramural vascular invasion. Finally, few words about the lymph nodes. Do you see any lymph nodes here? We can clearly see that there are a few tiny lymph nodes that are present in the mesorectum, and they're also showing subtle restricted diffusivity. So this is a lymph node which is likely positive. But does it really change the staging of the disease? Perhaps not much, because the N staging is very, very exhaustive. N0 means no suspicious lymph nodes. N1 has further been divided into A, B and C depending on how many lymph nodes are suspicious. If there is only one suspicious regional lymph node, it's N1A. If there are 2 to 3, it's N1B. And if there is no suspicious lymph node, but you see a regional deposit in the mesorectum, if you see a mass lesion in the mesorectum, then it's N1C. Then again, N2A and N2B depending upon the number. If it's 4 to 6, it's N2A. And if it's 7 or more, it's N2B. Now again, I don't expect you to remember all of this, but this is something that you should keep into your mind. It should be tucked somewhere in your radiology reporting room while you're looking at a case of CA rectum. Finally, this is the M staging. When there is no metastasis, it's M0 stage. If there is one organ metastasis without peritoneal metastasis, it is M1A. M1B is 2 or more organ mets. And if there is a peritoneal metastasis, irrespective of organ metastasis, it is a case of M1C stage. So this is all about carcinoma rectum, its MRI staging and everything that you need to remember in a case while you're reporting. And before we conclude this session, I would again want you to have a look at the list of the important findings that you need to mention in our reports once you see a case of CA rectum.